Okay, welcome everyone. We're going to get started now. So today we have the great opportunity to hear from our very own Dr. Davis on a topic called organizing teams to address healthcare disparities for patients with heart failure. Dr. Davis is an associate professor and the director of the heart failure program at the Zuckerberg San Francisco General Hospital. An SF native, he completed his medical school and internal medicine residency training at UCSF. He then joined faculty as a heart failure hospitalist for a year prior to completing his cardiology and advanced heart failure and transplant fellowship at WashU in St. Louis. During this time, he obtained a master's degree in population health science and then joined heart failure faculty at Oregon Health and Science University, where he served as medical director for mechanical circulatory support in 2015 until being recruited back to UCSF in 2018, when he developed and ran a heart failure program at ZSFG. He has since expanded and established the Heart Plus Clinic, a joint heart failure and addiction medicine contingency management clinic for patients with heart failure and stimulant use disorder, an epidemic in the Bay Area. So I'll hand it over to Dr. Davis. As a reminder, if you have any questions, feel free to put them in the chat or the Q&A box. And if you raise your hand, I can allow you to ask your question live as well.
Great, Joyce, thank you so much. And can you hear me okay? Still? Perfect. Wonderful. Well, thank you so very much for that kind introduction and for the opportunity to come chat with y'all today. I'm really excited to talk about some of the things that we've been doing out here at San Francisco General Hospital, and just to take you through a little overview of what we'll be talking about today. So very briefly, I want to spend the first few minutes discussing heart failure and healthcare disparities, and some of the drivers of the disparities and how we measure these disparities, and really kind of what led us to do some of the QI initiatives, quality improvement initiatives that we've done here over the last couple of years. Very briefly, I want to give an overview, which is a couple of slides talking about what the San Francisco Health Network is and how San Francisco General Hospital fits into that. And then really the bulk of our time are going to be spent talking about 3 target interventions, 3 team-based approaches that we did to really try to tackle some of these care disparities and improve care and access and care delivery for our patients here in San Francisco. So jumping right in, so what is, when we talk about healthcare disparities and inequity in heart failure care, what does that mean and kind of what does that look like? We could obviously spend a long amount of time just talking about these topics alone, but so I just want to give a little bit of a 10,000-foot overview in a couple slides just to kind of lay the stage for some of the things we'll be talking about for the bulk of the talk. So in terms of heart failure epidemiology, this is just one study from Eric, Mesa, and other large studies have shown similar things, that the rates of incidence of new heart failure per 1,000 persons in our community is not evenly distributed across different patient populations. In Eric, for example, incidence of new heart failure per 1,000 cases was 1 in Chinese Americans, 2.4 in whites, 3.5 in Hispanics, and the highest in African Americans at almost 5 per 1,000 person years. And along those lines, the 5-year adjusted risk of all-cause mortality for patients with heart failure was 34% higher for African Americans than for whites. So clearly there are disparities here, and we have to figure out like what's driving these disparities. And there's been a lot of literature published. There's a really nice article from a couple of years ago talking about the impact of social determinants of health and how much they weigh into the treatment of heart failure and management of heart failure. And as I'm sure you're all very familiar taking care of heart failure patients, that the comorbidities are incredibly prevalent and relevant in how we manage their heart failure care. And this was looking at patients, especially African-American patients, and some of the social determinants of health that they face that could be leading to some of the disparities that we highlighted on the prior slide. So access to care, medication adherence lower among African-American patients than white patients, impact of higher poverty and unemployment rates, lesser levels of higher education, health literacy, dietary habits, living in food deserts, lack of engagement with or distrust in the healthcare system. They're all things that impact our patients here at San Francisco General, at UCSF, and across the country, and things that really drive how patients are able to manage their heart failure, how they're able to manage their care in general, and things that we really have to do more job thinking about in terms of how we deliver heart failure care. And kind of what is this? What is the impact of these disparities? And well, publicly funded safety net systems such as San Francisco General, we care for underserved, under-resourced patients. We have unique challenges of care delivery and reimbursement. as you take a step back and think about heart failure, kind of why heart failure, that it is the common endpoint of many cardiovascular diseases: coronary disease, hypertension, AFib, valvular disease, and how we manage heart failure is really overall reflective of, and how much heart failure there is really reflective of the overall state of our system's cardiovascular care delivery. And how has this been measured? And Dr. Wafsi actually gave a really elegant grand rounds for medicine last week, and he's done a lot of research on this. So just going to touch on this for a few slides, but to explain kind of how CMS and how this is being measured, have to talk about, just explain very briefly this concept of dual eligible beneficiaries. So these are patients that qualify for Medicare based on their age, over 65, or disability, and also qualify for Medicaid based on lower income, 86% having below the federal poverty level. And this is what CMS uses to identify as a surrogate socioeconomic profiles of the hospitals around the country. So looking at dual versus single eligible beneficiaries for the next couple of slides, kind of talking about some of the issues that dual hospital systems or hospitals that have higher percentages of dual eligible beneficiaries face. And patients that are dual eligible are more likely to have multiple chronic conditions, cognitive and functional limitations, and institutional residence. And heart failure among all diseases contribute to the highest share of preventable hospitalizations at over 20%. And as we know, comorbidities drive heart failure. And patients with not just these dual eligible centers, high dual eligible centers, have higher proportions of these comorbidities that drive disease. So for example, dual eligible patients more often in safety net hospitals more tend to be Black, more tend to be female, coming in with acute myocardial infarction, coming in with heart failure, coming in with pneumonia. And of these folks coming in with acute MI, heart failure, pneumonia, they're more likely to have significant comorbidities, diabetes, major psychiatric disorders, dementia, which further complicates their heart failure care and their care overall. And why does this matter? What impact do all of these things have on the bottom line, how we take care of patients? That hospitals that are higher proportion of dual eligible patients have higher 30-day heart failure readmissions, higher rates of all-cause readmissions, less likely to receive important heart failure, achieve important heart failure process measures. So fewer beta blockers at discharge, for example, less measurement of ejection fraction and LV function, less anticoagulation for AFib or atrial flutter. And this can create a potential for a vicious cycle. So if we have a sicker patient population and we're unable to reach our metrics as well, that these disparities can only increase. And we have worse cardiovascular outcomes that are going to further fuel the disparities that we're trying to remedy. And if we don't meet these metrics, the way CMS is set up, even with modifications made in recent years, we're at risk for losing funding for these populations that are already being cared for in a resource-limited environment. So we're really at risk with these folks that are dual eligible to be behind the eight ball. What we have to do is kind of take a step back and think about the social determinants of health and how they're impacting our patients, how they impact our care delivery, and what we can do to meet the patients where they're at and address all of their needs. So transitioning now from kind of thinking nationally about dual eligible systems to the San Francisco Health Network, where we practice at San Francisco General. And I point this out because I didn't actually know this, even having been a resident here, didn't know this really till I joined the faculty here a few years ago, is that San Francisco General Hospital is actually part of the larger San Francisco Health Network, which has primary care clinics and mental health and the jail system, Laguna Honda across the city. And we actually take care of 1 in 8 San Franciscans. So it's a tremendous amount of San Franciscans that receive their care across the city, and all of the specialty care, all of the surgical care gets funneled into San Francisco General. And we have about 56% Medi-Cal, 20% Medicare, 9% uninsured. I put an asterisk there because, as you know, if you live in San Francisco, you're a resident, you are eligible for insurance. So if you come in, we'll get you plugged into insurance and be able to get you in primary care, et cetera. But we see a lot of heart failure. We see a lot of heart failure at San Francisco General. We actually have more new heart failure diagnoses presented to San Francisco General than any other hospital in the city. This is pre-pandemic, but looking at the volume of outpatient heart failure encounters that we see, this is for fiscal year 16 to 18. And you can see that this is between primary care, specialty care, clinic, urgent care, and emergency room visits, but outpatient, non-inpatient encounters for heart failure, we see almost as much as UCSF and Stanford combined over a given amount of time. So a lot of heart failure coming through San Francisco General. And prior to my hiring, things were not unfortunately going very well. And we had to take a step back and think about systematically and take kind of a lean and A3 thinking approach about what was going on. ZSFG in 2017 and 18 actually had the worst heart failure readmission rate in the state of California. In 2018, African Americans' 30-day heart failure readmission rate was 5.4% higher than that of whites. And as I mentioned, the penalties for not meeting the performance metrics, $5.1 million were at risk if we did not meet the CMS metrics. So we really had to go back to the drawing board. And I credit Luke Zier and Rachel Stern, who's unfortunately now moved on down to a major leadership role in Ventura, for really getting the ball rolling on these things and some of the projects that have been implemented over the last few years that have made some profound changes. But I'm going to talk about some of the team-based things that we've done. And this photo from a nurse that where I worked previously kind of exemplifies some of the things that we're dealing with when we think about medical care in general, heart failure care, health literacy. You can see pills on the near table, the far table, on the bureau, on the floor, off on the side. When we, especially for something like heart failure, which is so polypharmacy based. I mean, to put someone on ideal contemporary medical therapy is 4 medicines, 4 in the morning, Entrestos twice a day, and not knowing what's kind of going on in that person's life and how we can, best enable the resources that we have to care for the patients. That you can prescribe the medications, but if they can't take them, or if they have 16 other pill bottles laying at home that are old, we're not going to get the patients where they need to be. And so really taking a patient-centered approach. And as you'll see as we talk about some of these kind of bigger interventions that we've done in the last few years, that kind of rethinking kind of as opposed to just kind of coming into clinic, check in, and I'll see you back in a period of time, but really trying to do a patient-centered approach. And everything from values, integration of care, really thinking about the social determinants of health, access, empowerment, health literacy, continuity, and really taking a team-based approach and thinking about how we can put the patient at the center of care and figuring out what angles and what delivery and what things can we do to really engage that person. And as you'll see, the recurring theme is engagement. And how can we really empower the patient to feel like they are a key part of their own care in a meaningful way that we can then support and help improve. So the 3 interventions that I'm going to spend the bulk of the remaining time discussing are our multidisciplinary heart team, our heart failure titration clinic, and then the most novel thing that we've done in conjunction with our addiction medicine colleagues is this incredible Heart Plus clinic for patients with co-occurring stimulant use disorder, heart failure with reduced ejection fraction. And so we'll spend a lot of time talking about that. But jumping in first to the heart team. And this is something that got started at the end of 2018, beginning of 2019, and we meet monthly. And we discuss only those patients that have a very high rate of acute care utilization. And so Karen Chen, our data analyst, pulls the list of readmissions over the prior 3 months, and we just go to the top. Who has had the most readmissions, especially the most readmissions for heart failure? And we just start at the top, and each month we just work our way down discussing patients. So you're only getting discussed if you have a very high rate of acute care utilization. And as you know, and I'm sure you've seen, that if you're coming into the hospital multiple times a month or multiple times in a short period of time, it's often not the heart failure itself in terms of chronic disease. It's the social determinants of health. It's the housing, the mental health, access to medications, transportation, et cetera. And those are the things we really try to focus on. And so we always have heart failure cardiology. We have primary care, palliative care, addiction medicine, social medicine, and then depending on the patient and their background, social work, case management. We've had representatives from medical respite, street medicine, EMS6, all coming together to circle the wagon to discuss these folks and see kind of what we can mobilize on their behalf. And we have a very structured way that we do this. And I credit Christina Ryan, our incredible nurse practitioner in heart failure clinic. She does the chart extraction for this ahead of time. And in a standardized way, we pull the demographics. So age, gender, ethnicity, language, insurance status, that if they have a primary care provider, if they have a relationship with primary care or primary care clinic, past medical history, medications, at least that are prescribed, testing that's relevant, usually the cardiac focus, the echocardiogram cath, et cetera, heart failure treatment history. But then a significant bulk, and over half of it, is really about the everything else, about the care engagement history, the social determinants of health, substance use, mental behavioral health, if they have a treatment history for this, if they've ever been admitted for or sought more formal counseling or been involved in therapy, for example. We look at their housing status, existing resources, the pharmacy that they go to, have they filled medications, how did they get their medications, as well as patient assets. And so we go through this, each patient in a structured way, 1 or 2 per week, or per session, excuse me, one session a month. And kind of how did it go? Well, in the first year, and we've discussed about, we had a little bit of lag kind of during COVID, but the first year, as we transitioned from in-person to Zoom meetings, but in the first year we discussed 18 patients. And it was very striking. So 9 patients engaged with the interventions, whether it's going to a treatment facility, moving into a structured living environment, going to medical respite, engaging in complex care management, our very intensive outpatient-based care management program with nursing and social work, et cetera. The folks that decided that they were at the place that they could engage, or that they were ready to engage, or ready for a change, did incredibly well. And again, we are only discussing patients with very high rates, 3, 4, 5, 6 readmissions in the preceding weeks to months. The 9 patients that engaged in our recommendations, only 1 patient had 1 readmission in the following 6 months. It was incredible. Medical respite, complex care management, et cetera. These resources are amazing. And if we can get the patient to the right resource when they're ready, it can make a big change. However, the other 9 patients, for various reasons, were not ready to engage in the interventions that we offered. 3 passed away in the following 6 months. 4 more have passed away since then. And all of them that are still alive, unfortunately, continue to have very high readmission rates. So really this very striking, and kind of as I reflect on some of these things, is the engagement. And certainly as we now have conversations at our monthly meetings, we spend a big, and Jack Chase has been really wonderful kind of helping us think about these things too, is kind of how do we think about engagement? And yes, we can now, we know that if we can get patients plugged into some of these things, they can do really well. But what are some of the existing and ongoing barriers that have to be addressed and surmounted to get people to be willing and open and ready potentially to engage and have some of these other conversations about making changes? The second major clinic that we started was something called the Heart Failure Titration Clinic. As we were looking at folks who had high readmission rates, and we went through and reviewed about 100 patient charts. Again, Luke Zier and Rachel Stern, really tip my hat to them for getting the ball rolling before I joined. And access to clinic was a major issue, and access to titration of GDMT, of guideline-directed medical therapy, was a major issue. And so at the beginning of end of 2018, beginning of 2019, we launched the Heart Failure Titration Clinic, and it was specifically to meet the need for clinic access and medication optimization. It met at Monday night from 5 to 8 p.m. And we specifically chose the nighttime so that patients would not have to miss work to come to clinic. And the goal of this was specifically for medication titration and adjustment of diuretics for volume status. We were not going to see new patients. We were not going to see post-hospital discharges. This was just a very focused, we need to get your medical therapy, to get you on and up on your beta blocker, get that spironolactone started, et cetera, or following their volume status more closely. And we would schedule the visit. If I'm sitting in a regular visit with them, all right, can you come back next Monday night? Yes, great, let's schedule it now, pick a time. But we're also very flexible with that time. So yes, your appointment's at 5:30, but if they came early, they came late, we would still see them. So we tried to space them out for logistics and for clinic. However, from the patient perspective, they just had to show up, and we would see them and try to meet their heart failure needs at that time. So there are 4 specific goals with this clinic: to increase outpatient clinic contact for patients, assess volume status more frequently and more consistently ensure maintenance of euvolemia, to titrate guideline-directed medical therapy, and to reduce heart failure readmission rates at the general. The frequency of visits, so things that we looked at were kind of how frequently they came and how frequently they attended compared to our other cardiology clinics, and how many changes we made. And very excited that there was concern, oh, it's at nighttime, what's going to happen? Are they going to show? And our show rate for that titration clinic was actually the lowest of, it was lower than heart failure clinic, and it was lower than all the other cardiology clinics. 25% no-show rate for just general heart failure clinic. This is within the first year after we launched the clinic. The no-show rate overall for cardiology clinics was 21%, and for heart failure titration clinic, only 17%. And we were busy in these visits. So looking at kind of any medication titration, over 86 visits for HFrEF in that first year. Andy Nandan, one of the medicine residents, was outstanding in going through these data and pulling this together, and actually had an abstract published, and we're working on the manuscript. Any medication titration, 72%. Any GDMT, guideline-directed medical therapy, starter increase over half the time. Evidence-based beta blocker starting or increasing a quarter of the time. ACE/ARB, ARNI, MRA, diuretic titration. So very active at doing what we're setting out to do at these visits. And so people are showing up, having their medication changes, don't have all of the impact on readmission rate, as this kind of ran into COVID and we had to back off on the number of patients we're seeing in person. However, there's certainly a suggestion that people are staying out of the hospital more by warning of being on better medical therapy and being more actively managed for volume status. So still running titration clinic in a slightly modified form, given some outstanding clinic volume issues, but it's still been an incredibly useful tool for allowing patients to come in with a little bit more flexibility, not missing work, to have their medical heart failure medications adjusted. And that transitions us, we'll spend the last 20 minutes or so talking about is really the most novel thing that is novel because no one else has done it, is putting heart failure and addiction medicine and treatment for stimulant use in the same place at the same time. As I'm sure you've seen or familiar with from being in clinic or being on the wards, is that stimulant use can lead to a dilated cardiomyopathy. And Priscilla Shu has been doing a lot of work in this for a long time. And actually, Emily Cedarbaum, one of the current fellows, is I picked up the mantle with this, trying to find kind of more the causal pathophysiology between the two. But certainly association is there. Stimulant use driving dilated cardiomyopathy also obviously drives pulmonary hypertension, but we were focused on the heart failure population. And patients with co-occurring stimulant use and heart failure have increased mortality, have more frequent hospitalizations, have higher rates of depression, PTSD, they're more likely to experience homelessness, and more likely to be unemployed. Nationally, co-occurring stimulant use complicates at least 15% of hospitalization, so anecdotally it does feel like more. Here at the general, methamphetamine use is an independent predictor of heart failure readmission with an odds ratio of over 3.5. And there's no FDA-approved medication for the treatment of stimulant use disorder. So there are a lot of conversations kind of during 2019 with myself, Marlene Martin, who helped, and Soraya Azari start the addiction consult team here at the General, which is an incredible resource, and Sarah Lady, who was the addiction medicine fellow at the time. And just that it felt like there's a sense of like these folks are coming into the hospital, we're diuresing them, but then they're not coming to clinic. And how do we engage this patient population? They're clearly very sick. They come to the hospital all the time. They're not coming to clinic. They're not getting on medical therapy. Is there something else that we can do to try to reach out to them and give them an avenue to engage with care better? So thinking about a new approach, so directly observed therapy, reward-based incentives have been shown to be effective in chronic disease management, patients with stimulant use disorders, substance use disorders, and infectious disease. We think about this, for example, with tuberculosis and directly observed therapy, finding the person wherever they are and watching the diabetic, the TB treatment go in their mouth. That this has been shown in infectious disease. And actually, Jackie Desjardins, one of the fellows, and I wrote up kind of talking about this for a BMJ piece the other day, a few months ago, talking about how do we kind of take some of these things and translate them into stimulant use disorder, substance use disorder. Now, contingency management is an easily administered behavioral therapy, which provides positive reinforcements to promote the desired behavior. There's actually a state bill 110 that Newsom unfortunately did not sign into action to try to get payment for this, but it is the only treatment that's been shown to positively impact the use of stimulants. So contingency management is something that we want to implement in our clinic. And how does it work overall? So on the upper right, we have our urine drug screen. The patient will come to clinic, they have a urine drug screen done, they'll have a meeting, and I'll go through the workflow on the next slide. But the contingency management aspect of it is the fishbowl. And they get to draw tickets from a fishbowl. And as they draw the tickets, half the tickets are in positive reinforcement. Good job, keep it up, way to go, something like that. And the other half are worth money in the form of gift cards. And the more you show up to clinic, the more consistently your urine drug screens are negative, the more times you get to draw out of the fishbowl, and the more you can be rewarded. And this has actually been shown again in stimulant use disorder to be an effective way to get people to reduce and ultimately, ideally, stop their stimulant use. And so these are the things that we incorporated into the Heart Plus clinic. And so kind of overall kind of structure of the clinic that was initially designed pre-pandemic, we were looking for clinic attendance and to reduce stimulant use as measured by a urine drug screen. You had to have a documented stimulant use disorder and heart failure with reduced ejection fraction and be hospitalized in the last 6 months. So a very sick population with documented heart failure and stimulant use disorder. The incentives, so what the cards and what the values were worth, half of the tickets were worth just affirmations. There was a low reward, medium reward, and a high reward. And with decreasing probability, decreasing number of tickets, so you're far more likely to get a $5 reward than a $100 reward, but it was there. You came in for a twice weekly visit. So you came in Monday and Thursday to see addiction medicine. You would see cardiology, me, at least every other week, and more often for medication adjustments and titration. They would get their point of care urine. So that way they don't have to go to the lab, wait for it to come back. They could just do it right away and then see what's negative and get the draw. And we would plan for a 12-week intervention. So this was us getting started with Soraya and Sarah, who's actually now up at Seattle on the faculty up there. And so the workflow, they would see addiction medicine each time twice a week. We did twice a week because of the half-life, especially of the positive urine drug screen, that we want to have multiple touch points throughout the week to try to encourage as much cessation as possible, and also keep track and assist them with the counseling for their stimulant use. So they'd see the addiction provider, they get their point of care urine drug screen, and then they get to draw their tickets. And so the more serial visits you had in a row, so if you came 3 times in a row, you get to draw 3 tickets. If you had 5 negative urine drug screens, you get to draw 5 tickets. And so each time you came in, anytime you did a drug screen, you get to draw your tickets, and then you'd see the heart failure specialist, or more frequently, we had a specific checklist screening for symptoms at every visit, that if people having worsening dyspnea or fluid overload or what have you, could certainly see me as needed, but at minimum every other week, and for titration and symptoms. So our initial cohort at the beginning, this was in March of 2020, our mean age was about 46 years. All were ACC-HA stage D and NYHA class 3. Our mean BMP, you can see, was quite high at almost 2,000, and our ejection fraction quite low at 10 to 30%. And these are patients that have very high rates of acute care utilization, with a mean of 7 acute care presentations per year and a range of 4 to 15 visits in the prior year. So our initial cohort, we referred 28 patients were referred when we rolled 9. 7 of 9 presented to the first clinic, and 6 of 7 presented to the second clinic. That only person, that 7th person, missed the clinic because he was in the emergency room for gout. But everyone showed. On the first day, we did not do a urine drug screen just to kind of get people into clinic. The second day, the second session, we did a urine drug screen, and everyone had a negative drug screen that first time. We up-titrated heart failure medications on everyone. 6 out of 7 patients that week had their heart failure meds up-titrated, and we definitely averted at least 1, if not 2, but definitely 1 ED visit for volume overload by increasing the diuretic at that first visit. So we were very excited. The first week went really well, and then COVID happened. So stay-at-home orders, no in-person visits. So unfortunately, after 1 week, we had to stop our in-person visits, but they didn't stop us. We were able to, with vaccines and changes, we were able to work with the clinic leadership, and we resumed Heart Plus with a few modifications because of clinic rules and protocols. So we kept it at twice weekly, but we switched it from half of the visits were in person and half by phone. So for example, the Monday, the half came on Monday in person and half by phone, and on Thursday, the other half would come in person, the other half would have a phone visit. The thing that made this a little tricky was that you had to have a telephone. And unfortunately, a lot of patients in this population didn't have a phone or a working telephone. But to meet the needs of the COVID and not having so many people physically coming to clinic, yet still being able to see our patients, we tried this version for our 3-month pilot. And we did it with rolling admissions. So how much was this going to cost? So the question, we get asked a lot of questions about this. So is it going to work, and how much is it going to cost? So over a 12-week period, if one person shows up to every single visit, has every single urine drug screen be negative, on average, that will cost $441. And if we do a 10-patient pilot, assuming that attendance is about 50%, it'll total, again, because each time I draw, I could have a 50% chance of getting a positive affirmation, and then there's a 40 some odd percent of getting a $5, and then it goes down per percent. So $100 is only a 2% chance. So the average cost can vary. So on average, it would cost about $2,200 in total gift cards for a 10-person pilot, assuming 50% attendance. So what did this second cohort look like? So we had 38 patients referred. 12 patients attended the first visit and completed consent. 9 patients continued after the first visit. And I'm going to talk about the 12 and 9 in just a minute and why that's important. A big thing, though, was unfortunately telephones and having access to a telephone. There's actually one person who had a phone with lousy service, and Dr. Azari would actually text the patient that we're ready for the visit. He would go somewhere and then call her back when he was by a different phone. But overall, that was a key thing. But this is a group with a lot of social determinants of health issues. 3 of these patients that enrolled were living in shelter-in-place hotels. 4 were living in single-room occupancy SRO apartments. Similar to the prior cohort, mean age was about 56. 92% were male, 50% Black, as you can see, and median ejection fraction was low at 29%. Only 3 of the patients that enrolled had been cared and been engaged in cardiology clinic previously. And again, everyone had to have stimulant use disorder to be enrolled. 75% used methamphetamine, 25% used cocaine. So we had 12 patients that we enrolled for this. And so did they show up to clinic? And that was going to be one of the major questions we want to see is, will patients show up? And this is a group of these 12 patients that did not have a track record of coming very often to clinic. And unfortunately, that's very consistent with this patient population. That the median clinic show rate in the 6 months before the intervention was 33%. During the pilot, the show rate for the in-person visits, we'll talk about telephone and in-person in a second, that the median clinic show rate for these whole 12 people was 56%. So you can see significantly higher, closing on twice as high as their show rate pre-intervention. And again, we're asking a lot of visits of these patients, right? We're asking for 2 visits a week, 1 in person, 1 by phone, every week for 12 weeks. So this is a high amount of visits that we're talking about here. Now, 3 people only attended that very first visit. 2 of those folks had actually been in the hospital, were discharged and put in a wheelchair and rolled from the hospital down and over to clinic. Neither of those people continued afterwards, and then there's 1 other person who only came for the first visit. And this really gets to the engagement piece, and we talked about this with the the Heart team, is engagement and being ready and in the position to engage with whatever intervention, in this case, the Heart Plus clinic. And so we talked a lot about that, 2 of the people of the 3 that didn't continue, they didn't really have the choice, right? They didn't have to get from where they're staying and where they're living to come to clinic. They were put in a wheelchair and brought over. And I think that's really key is, why we refer so many people, but, we have to find folks that are ready. And if you're ready, you did really well. So if we take out these 3 people, they came to clinic a lot, 80%. I mean, that's fantastic. The median clinic show rate was 80% for the other 9 patients for the rest of the stay, excluding those 3 people who only came the very first time. So if you showed up to a second, you were incredibly likely to stick with the program throughout the rest of the time. Telephone show rate, again, even though you had to have a phone to get into this, the show rate for to have a phone visit was still much lower at 50%. But I think it's just so striking that you have folks that were showing up a third of the time before here and now showing up 80% of the time for this program. And that is the goal, right? We want to get these folks into clinic so we can treat their addiction, we can treat their heart failure, and keep them out of the hospital. Not to be cynical, but this is something that obviously it's incredibly expensive. And how many admissions or ED visits do we have to avert by doing this program? So looking at our patient population in terms of acute care resource utilization. So coming to the ED for any cause, any admission. We did not break these down by, well, they came in for gout, they came in for heart failure, they came in for whatnot. Any ED presentation or admission in the 3 months prior of our 12 patient cohort, 21, I excluded one person who had about 15 admissions before, 15 admissions during, and 15 admissions afterwards. He was one of the people that did not continue with the program. But excluding him, everyone else, in the 3 months prior, the other 11 people had 21 acute care presentations. During the 3-month pilot, 10 acute care presentations. And since the pilot ended, 16. So not enough to really get a p-value, but certainly very telling that during this presentation, during this pilot program, we were getting people to come to clinic that historically didn't come and keeping them out of the hospital, out of the emergency room, where historically they're very frequently likely to go. And I just was really blown away by these numbers when we finally saw them at the end. Because it's interesting, because we think about the stimulant use component of it, think about the heart failure, think about the stimulant use, that all participants reported reduced use. However, only one person went to complete abstinence from use. And as we think about, and I think there are a few of my addiction colleagues on the listening in today, but in my mind, thinking about harm reduction, thinking about decreased use and decrease of the things that come along with use, that if we can move people in just a 12-week period towards reduced use, that is a step in the right direction, especially if they're coming into clinic and not coming in to an acute care setting doing much poorly. Interestingly, the majority declined urine drug testing during their in-person visits, but they all reported, again, a decrease in their use, whether it was from instead of many times a day to once a day, or instead of every day, once a day, in terms of fewer days of the week. In terms of cost, range per patient, anywhere from $500 to $400. Median was $147.50. And the total for us at the end of the pilot was just under $1,700. So if we think about from a rewards perspective in terms of buying gift cards, under $1,700 for that many fewer acute care presentations. And given the cost of coming to the emergency room, especially the cost of being admitted, I think in my mind, this is a pretty good trade-off. So we also really thoughtfully, and Leslie Suen really drove a lot of this, the qualitative results. And so at the end of this, she and Andreas Mitchell, one of the medicine residents, brought everyone back that would come and just had a conversation with them about how did it go? What was your perspective? And there were really 3 themes that emerged from these qualitative results. Theme 1, non-stigmatized care facilitated hopefulness. To have people who give a damn and don't judge you because of what you do, your lifestyle, that's a miracle and a blessing in itself. And to see people give a damn, it's like, wait a minute, they care so much about me. Maybe I should care about me. Theme 2, patient-provider relationship was essential. When my doctor pops up behind the glass and she acknowledges that I'm here, that I'm present, it always feels good inside that I have a person that's rooting for me all the steps of the way. And that always feels good to have somebody that's walking with you through the darkness. The third theme is that Heart Plus changed participants' view of their own health and drug use. When I came here, I noticed that, I don't crave that much. Today I'm clean. I'm supposed to be getting high. That's not me, right? I noticed that my using is fading away. Hopefully it'll be for good. So just really moving how this clinic impacted people. And I'm really glad we did this part of it. And it's just incredible. So this leaves us with some unanswered questions. How much of the decrease in stimulant use or acute care resorption that was so exciting during the pilot, how much do we have to get of that to warrant the cost of the program? So along those lines, what's the impact of the durability of reduction in stimulant use, of the increased medical therapy use, of the decrease in heart failure readmission rates? If we do this program for 12 weeks or for twice as long, what happens afterwards? And now we're collecting data on now as our pilot just recently ended. And then institutional support for twice weekly clinic. So you have to have clinic twice a week. You have to have contingency management and supplies for this. And you have 2 subspecialists between addiction medicine and cardiology seeing patients. And so getting the institution to help finance this and give us a place to see these patients and reach these patients and try to continue what we're doing. Fortunately, though, we're going to be, and I've been asked about this a lot, we are going to be reopening for round number 3, hopefully in the next month or so. We just a month and a half or 2 months ago received an internal grant from the Strategic Use of Reserves Fund through ZSFG for $30,000, which is going to help us get more gift cards and more time and more providers to help reopen this promptly to keep going. So we're very excited about this. So in conclusion, just the last few minutes, then we'll take some questions. The impact. I showed you at the beginning that in 2018, things were not looking good. Our readmission rate was high. We were at risk for losing money. Our care equity gap was high. And so how did we do with these interventions? I only mentioned 3, the heart team, the titration clinic, and Heart Plus. There are many other things that we put into place. Luke and Rachel's discharge planning tool for inpatient heart failure management and several other things. But globally, if you look all the way on the left, our overall readmission rate in 2018 was 28%, and we had a significant reduction all the way down to just over 21% by calendar year 2020. African Americans, unfortunately, still had a care equity gap, starting at 33.5%. However, our equity gap closed. Our delta between African American patients and the rest of our population fortunately narrowed over this time from 5.5% down to 2.5%. And hopefully through continued interventions, continue to close even further. In fact, just close altogether. There is a consortium of the Essential Hospitals of America that has safety net hospitals such as San Francisco General. And we submitted a grant for $100,000 to help do some of these infrastructural things to help reduce care disparities. We just found out last week that we were a finalist for that. So that would be incredibly exciting to try to take and systematically do some of these things in a more broad fashion. And we kept the money. So we saved the hospital that year $5.1 million, and fortunately been able to meet our metrics since. And so that's also very good. So some key points just in the last 2 minutes here. Guideline-directed medical therapy, our ARNIs, our beta blockers, our SGLT2 inhibitors, they don't work in isolation. We can prescribe them, it's easy to prescribe them, but the patients have to be able to get them, take them, know why they're taking them, and do everything else from a comorbidity perspective that we ask of patients to manage their heart failure. Need to put social determinants at the top of the problem list. That again, prescribing things is only so much. We have to make sure we are thinking about health literacy, clothing, food, and shelter, that they're so critically important to take care of our patients. And we can do it. We just have to think about doing it and think about how we do it. Proactively build the care team around the patient. And we've talked about this a lot over the last 40 minutes or so, that in the care team around the patient can take on different, it can be with the patient like Heart Plus, it can be as a team, it can be individually with one-on-one with the patient, something like titration clinic, or it can be a whole, getting all of the wagons together, circling the wagons in something like the heart team to bring everyone together to think about how the patient is doing and where they're at and what we can rally. And finally, we have to be patient and can't give up. There's so much that we want to do, so much that we can do, so much that we try to do, and we can do it. It doesn't happen right away. Even interventions that we look at that were successful, the heart team with our huge reduction in readmissions, if the patient was ready to engage in that patient population. Heart Plus, we got to have Heart Plus available in people that are, when they're ready to do it. And, again, we referred more people than we actually enrolled, and kind of what are the barriers there, and kind of thinking about other ways that we can reach these patients in a proactive way to help get them the care that they need. So with that, I have a couple people that I really want to thank. Absolutely to Luke Zier and Rachel Stern. They were the ones that really started this in 2018 and actually helped lead to my being hired. I want to thank the chiefs over the last 3 years, Peter Gans, Mary Gray, and now Priscilla Shu. Peter was chief when I started, and then Mary, and now obviously Priscilla. And I just want to thank you for your mentorship and support. And then folks that are doing the work. So Christina Ryan, one of the nurse practitioners in clinic who does the chart extractions for our heart team every month, and also just incredible practitioner. Karen Chen, Lily Morales, and Jamie Martin in the quality office, thinking about data analysis and thinking about these things from a structural and quality improvement perspective. And then Amanda, Chanel, and Claudia, where incredible how one nurse and one MA run the entire cardiology clinic for the city with 15 plus providers. I don't know how they do it, but I thank you for doing what you do. And then the right column is our Heart Plus team. And it's a big team: Elizabeth Abbs, Raya Zari, Sarah Lady, Leslie Suen, Marlene Martin, and Andreas Mitchell. Just it's a huge team, and really very fortunate to be able to work with everyone. So with that, I will stop. We have about 10 minutes or so for questions and comments and anything else. And again, I just thank you so much for allowing me to come chat with you about some of the things we've been doing out here at the General.
Thank you, Dr. Davis, for a wonderful and very insightful talk. Again, for the attendees, please put your questions in the Q&A box or the chat. And if you raise your hand, I can try to allow you to ask a question in person. We already have a question from Dr. Peter Tang. Quick question, do you give IV diuretics in your PM clinics, the one where you discussed meeting with the patients to review their medications?
We do not.
Very quick question. I actually had a question about any thoughts or approaches to incorporating the inpatient experience. So for example, kind of devising this like pipeline, because I think it's very key or and important that you've mentioned a lot of the factors that go into whether or not someone's gonna come back to clinic over and over again is whether or not they feel like a part of that team or feel a good connection with the team in the heart failure clinic. So have you guys thought about possibly involving anyone in the outpatient team and meeting with patients who have hospitalizations for heart failure and to see whether they can improve the relationship with those patients and increase the likelihood of following up in clinic?
Absolutely. And the teamwork is I cannot understate the value. And especially here where referrals come from primary care directly to heart failure clinic, as opposed to general cardiology and then to advanced heart failure. So I work very closely with the primary care providers. I make sure that every single time I see a patient in clinic that I've sent them a message to say, hey, I saw your patient, they're doing fine, or I saw your patient, they're not doing fine, X, Y, and Z came up in our session today, as well as forwarding my note. And these partnerships are incredibly important. And there are other things such as complex care management and obviously the home health, home nursing, to try to be greatly involved in those conversations, especially with the home nurse that's going out. Like, I want to know what their weights are and what their blood pressures are. But trying to kind of foster this team-based approach, and also just building out heart failure clinic. I mentioned Amanda and Claudia and Christina. We also have Farhad Surti, another nurse practitioner who's incredible, who joined our team about a year ago, to try to have more clinic availability to see more people as an outpatient, try to prevent them from being an inpatient. We've talked with Priscilla about creating an inpatient consult team, kind of an inpatient process more formally, beyond just the discharge planning tool and kind of the GDMT aspect of it, but that hopefully something in the future. I hope I answered your question. I think the key is really partnering with primary care and the other resources from social work, mental health, case management as much as possible, and not simply saying, all right, well, your volume overload, I'm increasing your diuretic, I'll see you in a few months, but to really be as incredibly engaged with the rest of the care team.
Yeah, and I know we've talked about it, the importance of keeping the primary care team involved, especially when we have patients who go to so many different hospitals. So I think that's important to highlight. We have a couple more questions coming in. So Dr. Shu asked, how do we support referrals for advanced heart failure therapies or advanced therapies, including VAD or transplant, in these challenging patient population?
A great question. And I know Dr. Klein asked me the same question a few weeks ago. Interestingly, when I came down here, there was an anticipation of a large number of patients being referred for VAD and transplant. And interestingly, a significant number of those patients they needed medical therapy. And medical therapy, I'm going to get in trouble for saying this, but medical therapy is really good. It's a lot of pills, but ARNI, SGLT2, MRA, and beta block, they're really good. And I think everyone really deserves a good college try. And I was talking actually with Amanda about this morning, someone who 6-7 months ago was in a wheelchair, could barely walk with a walker, and no ejection fraction, AFib, and alcohol use disorder. And today he walked in kind of spinning his cane, just kind of as an accoutrement. Patients can do really well if we get them good medical therapy. But I think also the other thing is, knowing some of the social determinant issues that are very relevant for advanced heart failure therapy, clothing, food, and shelter, obviously housing, social support, that we have to be able to mobilize those things on our end. So if their heart failure does advance, that they don't just go up to the transplant center and say, well, gosh, you're living by yourself and your family's nowhere to be found. Trying to create the infrastructure and resources to try to mobilize these things early is going to be necessary, because there are plenty of people that are, with blinders on, objectively sick enough cardiovascularly for a heart transplant, but the rest of them needs support, and that's hopefully what we can with all of these things, and hopefully we get that grant from the Essential Hospitals of America grant, which will help us create that infrastructure to have more people that, if they're sick enough to need it, be in a position to get it. And I see Jackie. Any plans to formally study patient-centered outcomes in patients enrolled in Heart Plus? So we do have the qualitative things I talked about with the 3 themes to try to get at this as much as possible. In terms of specific non-cardiovascular outcomes like psych admissions, we were looking at kind of admissions and acute care resource utilization overall, just kind of counting how many times they'd come in, was not breaking down to see how many were for medical and non-medical, or heart failure, non-heart failure related. I could say in an ideal world, we would have a therapist, both for not just for Heart Plus, but for heart failure in general, given the incredibly 4 to 5-fold higher rates of depression in heart failure population than general public. Bringing psych in is something we had not talked about. Would be great, and maybe that's something to think about as we move forward. But we are trying with these quantitative assessments in these interviews to get at the patient-centered outcomes.
We have a question in the Q&A by our own Jesse Holtzman, one of our awesome residents. Has there been any interest on the part of Medi-Cal or Healthy SF to incentivize this team-based approach to allow to scale up and with insurance support?
To my knowledge, the short answer is no. The closest thing, and I'm not going to be able to speak with this as articulately as some of the other folks in the audience, but State Bill 110, SB 110, that had been put forth to try to increase approval for actually funding and Medicare reimbursement for insurance reimbursement for contingency management. And unfortunately, that was vetoed by our governor a week or two ago. Actually, no, October 8th, last Friday, it was just vetoed. So in terms of kind of formally getting funding for the contingency management, for example, aspect of it, not there yet. Certainly that trying to, as we pitch these in A3s and other things to clinic leadership, showing kind of the delta between more clinic and less acute care, we're hoping that they'll support us. But the SURF grant that we just got, that we definitely do have, that's kind of one part along the way of at least demonstrating benefit. And hopefully the hospital leadership agrees and can fund this long term.
Great, that's great. And then Dr. Goldschlager asks, are there any interim support groups, such as meetings among patients, that occur in between, I guess, formal clinic?
There are not, and the biggest reason for that is obviously with COVID and the limitations for number of people that can be in the same place at the same time. That was unfortunately, for example, why we could only have half the clinic visits, not all the clinic visits, be in person, and have had to be by telephone, just in terms of how many people are physically in the waiting room waiting for their visit on any given night or morning, or depending on when the clinic was. Having a heart failure support group, obviously a VAD support group and transplant support group, having a similar support group would be incredible. And certainly from a mental health perspective, that's something that's been clearly shown to be beneficial. So I think once we're allowed to start having more people in the same place at the same time, we would love to do that.
Yeah, I think it's really important and really critical to think about how those limitations occur in different patient populations. One of my continuity clinics is at the General, and it's amazing how many patients I'm not able to reach because they just don't have a phone, and we don't necessarily have a plan for how to continue seeing them other than when they do present to the hospital. So I was wondering if you could comment a little bit about like the resources that you have needed to maintain some of these efforts, such as having a PM meeting time with your patients to talk about their medications, or allowing a little bit more wiggle room for patients who do present late knowing that the reasons why they're late are because, they're working throughout the day, or they couldn't catch the bus, or et cetera, all of the other reasons that come up.
Absolutely. And for example, think about the telehealth. It's something that, Priscilla and Amanda has been pivotal in arranging with Tommy Dooland and Byron Lee, is electrophysiology, for example. And, a lot of the visits are done remotely, by Zoom and on an iPad or what have you. And a lot of patients don't have that. So we actually, credit to, Priscilla and Amanda for doing this, and Tommy and for Byron for being flexible and doing this too, is we actually would have patients physically come to the general and use an iPad in one of the clinic rooms to Zoom into their EP visit. Because it was still just a lot easier for the patients to physically get to the general than it was to get up to Parnassus or down to Mission Bay. So they were coming in person for a virtual visit and still getting an EKG in clinic. So those are some of the things that we kind of have to think a little bit differently about how we think about technology and reaching out to our patients. Signing up for MyChart. I'm like begging people to sign up for MyChart, and it's interesting. There've been many patients where we get their smartphone out, we kind of go through it, and go, all right, pick your username and password. And it just, for a lot of folks, it's a very foreign concept of picking a username and a password. There's a lot of kind of different things that we have to think about. What are the resources and what's available? So that kind of remote Zoom thing. The Monday night clinic, they're actually primary care meets at night. So I was able to just take a primary care room and use that for the titration clinic, and obviously kind of double dip for that for Heart Plus. But that's it's part of my FT to go to clinic, and that clinic's on Monday night, and that's just when it works. I think I covered most of the big things that you mentioned. Is there anything else that you were asking about?
No, that was great. I don't see any other questions that have come up, but thank you, Dr. Davis, for such a wonderful talk. Thank you, everyone, for your wonderful questions as well. And we'll be seeing you next week.
Wonderful. Well, Joyce, thank you so much, and everyone who listened in, thank you. And I really appreciate the opportunity. And just thank you very much.